In 2004, he began writing a humorous series of emails, which later converted to a blog about his many medical experiences, both good and bad, using witty pseudonyms for his various physicians. And this is the link to that blog is here. And it was noted that during his last year of life, this blog became quite popular, even among people who had never met Tom. In the last few years of his life, Tom became an avid nature photographer. He posted many of his photos on Facebook, accompanied by clever anthropomorphic captions. And I clipped one of the photos from Facebook here, accompanying this slide. So this is the Tom that I knew, both a wonderful human being, a very competent and engaged physician, and a real advocate for tuberculosis control in Massachusetts. And with that, I think we're going to hear a few words from Kathleen Linda. In 2004, he began writing a humorous series of emails, which later converted to a blog about his many medical experiences, both good and bad, using witty pseudonyms for his various physicians. And this is the link to that blog is here. And it was noted that during his last year of life, this blog became quite popular, even among people who had never met Tom. In the last few years of his life, Tom became an avid nature photographer. He posted many of his photos on Facebook, accompanied by clever anthropomorphic captions. And I clipped one of the photos from Facebook here, accompanying this slide. So this is the Tom that I knew, both a wonderful human being, a very competent and engaged physician, and a real advocate for tuberculosis control in Massachusetts. And with that, I think we're going to hear a few words from Kathleen Linda.
Hi, I'm Kathleen Gillespie. I was Tom's wife. I'm going to cry. That's inevitable. Thank you so much for naming this series of lectures for Tom. His family is grateful. As Ed explained, this was dear to his heart, spreading the word on tuberculosis control. He loved working with MACET. He loved working with legislators, and he especially loved working with staffers for legislators, because he felt like every year he'd get a new crop of young, eager, interested, intelligent people who he could sort of spread the word to about the importance of this work and of funding the state lab generally. So I wanted to thank you all for this, and thank you, Ed, for sort of, laying out the personal part. He used to say that he was pursuing adventures in experiential medicine, because he basically had every test known to humankind, and most of the surgical procedures as well. And I think it brought him a lot of empathy, and I hope that he brought that to his advocacy work, and I'm sure that he did. So thank you very much, Ed.
You're welcome, Kathleen. Thanks for being here.
Great. Thank you both so much for sharing with us today about Tom, his life, his work, his passions, and it just really makes it clear why it's such an honor to be here celebrating him today. So thank you both. Okay, so I'm pleased to introduce our first speaker today, Dr. Karen Jacobson, who will be discussing the state of TB. Dr. Jacobson is an assistant professor of medicine at Boston University School of Medicine and the medical director of the Boston Public Health Commission, Boston Medical Center Tuberculosis Clinic. She focuses her research on the epidemiology of tuberculosis, including identification of biological and social determinants of risk factors for both tuberculosis infection and disease, and studies approaches for improving tuberculosis outcomes in resource-limited settings. She is the lead PI on NIH-funded projects in South Africa, investigating the impact of substance use on tuberculosis. With that, I welcome Dr. Jacobson.
Great, thank you. Thank you so much for including me today, and it's an honor to get a chance to review where we are today on World TB Day. So I was asked to briefly go over just an update both globally as well as here in Massachusetts about where we are with the state of TB. So I think Ed actually helped me with this already, but I just wanted to remind everyone where we were a year ago when we were looking at the global statistics. We've been pretty consistently with about 10 million people falling ill with tuberculosis annually, which is a case rate of about 130 per 100,000 persons. There's continued, always had been recognition in the last few years that there's gaps in who is actually being successfully identified and linked to treatment. It's believed that at least 3 million of that 10 million are not successfully diagnosed or reported. And this has led to an estimated 1.4 million deaths annually. Until 2019, there has been some success in reducing incidence with about a 2% reduction per year and an estimated 9% cumulative reduction between 2015 and 19. Here in the United States, we had actually in 2019 our lowest incidence rate since reporting started of 2.7 cases per 100,000 persons, meaning there were about just shy of 9,000 cases in 2019. And really all of this was really going towards the WHO NTB strategy goals, which is aiming to get 90% reduction in incident cases by 2030 and 95% by 2035. However, at the rates that we were going, we definitely needed additional innovations, including potentially improved and short treatments, potential vaccine, because the just pure implementation of the methods that we have currently really were not speeding things up enough. But as Ed alluded to, and all of us know, we were hit by a second infectious pathogen global pandemic, and even part of the way through last year, there was a recognition that COVID-19 is drastically setting us back in terms of progress towards these goals. It's been estimated that there would be an additional 1.4 million deaths between 2020 and 2025 because of these setbacks. And the question is why? Well, I think, again, we know that last year as the world shut down, things also shut down when it came to TB care. And so a survey done just between May and June of 2020 already indicated that many of our medium to high burden TB countries were struggling with actually delivering care. Reports from Kenya were that as high as 50% of people with TB were having trouble finding transport to get to the care facilities to receive treatment. 36% of individuals surveyed in India reported that their health facilities were closed when they went to get care, their TB care, and that overall there was just a sharp depression in the number of cases being reported during this window because of lack of diagnosis. And from this, it was estimated that as many as 500,000 additional deaths may have occurred last year due to undertreatment of tuberculosis. And this week, the Stop TB Partnership put up updated numbers in recognition of World TB Day. They estimate that we've actually now, in the last 12 months, while the world turns its focus to COVID-19, we may have lost as many as 12 years progress in the global fight for TB, and that we may be looking at 2008 levels again in terms of TB burden globally. Globally as well, we see a 20% reduction in TB diagnosis and treatment, and this is ranging from 16 to 40% from our 9 highest TB burden countries. We also are starting to see some indication that having tuberculosis and COVID-19 is leading to higher rates of mortality than having TB alone. So we have a new comorbidity to be considering. Here in the United States, I assume we'll be hearing additional reports this week as well, but at the North American Union meeting, there was a very nice talk that was starting to show our US data, and here as well, and I'll show at the end what we're seeing in Massachusetts, we also saw about a 23% decline in TB cases reported. This is a sharp difference from what we've been seeing, which was really a drop of only about 100 or so per year in the prior year. And the question is, why are we seeing such a drop here in the United States? It's a little different than in some of our other settings in the world. Part of it may be driven by the lack of travel, since we know such a high rate of TB is imported into the United States. But we also know, both locally and across the U.S., that there's less in-person screening. And potentially, we know that many of our staff who are most talented for finding and treating and tracking TB were reassigned to COVID-19 activities. But we also had some successes in the field of TB this last year, and I wanted to make sure that we look at those with giving us some hopes on the way forward. So we continue to really get some progress in detection and diagnosis. I think increasingly we are seeing both here in Massachusetts and in many parts of the world a real pivot to look at more rapid molecular tests and drug susceptibility tests to get more universal access to these mechanisms. There's no question that expert MTB risk and expert ultra really already expanded capacity in many settings. And the hope is that the expert MTB XDR cartridge or other molecular tests getting closer to point of care will help. We also know that there's been great progress in thinking about other biomarkers for TB. There's been an increased recognition of incipient and subclinical case detection needs, not waiting until patients already have clinical symptoms. And some of this has been based on RNA sequencing, which you see some of the ROC curves here in this figure. We also know that having non-sputum-based diagnostics will improve and help us, and that some of these markers can also help with host response. And I think, again, there's been an increasing pivot towards thinking about how radiography can increasingly be used even in lower resource setting as a screening tool. An example of thinking beyond symptoms, I think, was really evident in the first national TB prevalence survey in South Africa, one of our highest burden countries in the world. Again, compared to here, you see exponential rates of TB, 852 cases per 100,000 persons, which was found. We see what we've seen traditionally, that this is a disease more often seen in men, that those of the ages of 35 to 44 have particularly high burden of disease, and that there needs to be a continued focus as we all go forward globally on youth and males, because they are the ones who present latest and appear to be less engaged with clinical settings. Interestingly, this survey also found really high burdens of symptomatic persons not taking care who are HIV uninfected, and I think the co-infection has been a focus because of the amazing network that HIV Care has set up, but we need to recognize as well that the HIV uninfected individuals continue to contribute to this pandemic greatly in many settings. And that we also, similar to COVID, need to be thinking about this sort of asymptomatic or pre-symptomatic phase in individuals when we're looking at care. It's estimated in South Africa, even in 2018, that probably almost 40% of cases were actually not detected in the system. And so we need to think about how we improve systematic screening for TB disease. I think other trials around treatment shortening therapeutics are starting to come through, which is very exciting. So this is a schematic from the Study 31 4-month treatment regimen shortening. And what they found is that the 4-month therapy appears to be non-inferior compared to our traditional 6-month regimen for drug-susceptible TB, which could be a real breakthrough if we see continued progress on that this upcoming year. And I think there's also ongoing recognition that when someone finishes their TB care, that their complications from TB probably do not stop there. And so this is a really nice infographic put out by our colleagues in British Columbia, saying that, again, TB survivors need recognition and ongoing support and links and continued monitoring of their lung health, their mental health, their cardiovascular health, and so on. So more locally, what are we seeing? So this is courtesy of Andy Tibbs and Jennifer Cochran, shared these slides from the state. Not surprisingly, we see a similar drop in the number of cases per 100,000 that were reported and diagnosed in 2020, a more sharp drop in the darker blue line than was seen in previous years. Our ethnic distribution of cases is shown here, and is as you can see, for the most part similar, although it's interesting that when we see some of the drops in which populations were less diagnosed or potentially had less cases in this past year, there's a larger drop among our patients in the state of Massachusetts of Asian and Black backgrounds. What we see again in terms of our number of cases with this drop is that it still remains that a high % of our TB cases in the state of Massachusetts are among individuals born outside the United States, and that did not change in 2020. But really the takeaways are that we have been impacted in Massachusetts by the COVID pandemic. There was a 20% decline in cases. There's about a 40% decline in reported latent TB infections. This is our preliminary data, but I think it goes again to say that people had trouble engaging with and getting into their primary care settings. The question is, will this persist or will we go back up to our previous baseline? Were some of the dynamics changed by changes in respiratory precautions? How does the decreased international travel translate into how many cases we see in the next few years? Were people not presenting with more mild cases, or will we see more advanced cases in the upcoming year or two? And was there any cases of underdiagnosis because of distractions looking at COVID-19? The other interesting piece of data that the state gave was that 98% of the culture-confirmed isolates that were genotyped showed that there didn't appear to be any evidence of local transmission, which matches with what we've seen in recent years. So thank you. I hope that gives you a sense of where we are now, and hopefully after what's been a bit of a rough year, some optimism of things that we can do going forward and hopefully catch up.
Thank you, Dr. Jacobson. Okay, so before I move on to Dr. Champel, I just do want to remind all the participants, any comments or questions that you may have, please put that in the chat box. So we will hopefully have some time at the end for a discussion. And so now for the keynote lecture will be presented by Dr. Cynthia Champel. The lecture is entitled TB, Policy, Economics, and Equity, Using Multiple Lenses to Strengthen Pandemic Response. Dr. Champel is a research scientist at Brandeis University. She has served on the Massachusetts Medical Advisory Committee for the Elimination of Tuberculosis for 17 years and was recently elected chair-elect of the Stop TB USA Coordinating Board. The National TB Controllers Association awarded Dr. Champel their Charles de Gras Award in 2011. And with that, I am very pleased to turn it over to Dr. Champel.
Thank you to the organizers for this amazing honor to give this lecture. And I'm going to start my camera as well. And I also want to thank everyone for being here to hear about such important work and an important topic. Quick disclaimer, I have no conflicts of interest, but I do have I'm very strongly biased in the pro-TB elimination realm. Quick overview here, we're going to acknowledge the TB community contributions to the COVID-19 response, and then we're going to weave policy, economics, and equity and put them in conversation and actually celebrate some successes when those three things intersect successfully. And then we're going to shift gears a little bit and go into some health equity and public health messaging best practices. But to begin, grounding us, 10 years ago today, this is World TB Day in the State House with Tom and Eugen Janice Lee from Health Resources in Action and myself. All right, TB folks really gave us a running start with the COVID-19 response. I mean, who understands better the isolation and support services, the disease reporting and tracking system? I remember jumping out of my seat when I heard an NPR story. One of the talking heads said, "We don't know how to do contact tracing for airborne diseases." And I said, "Are you kidding? Not only do we know it, the TB people know how to do it the best." They were, consulted or actively recruited and or actively training all of the COVID-19 tracers. That expertise pretty much 100% came from the TB world. The story and the history of the N95 mask is absolutely fascinating. I mean, TB features critically in that development. In the resources page that's going to be available along, I believe, with a recording of this, or at least the slides, is a link to a podcast, the Through Line, and it gives the history of the mask. It's a great listen if you're walking your dog or doing the dishes. The Gene Expert machine, the broader TB community worked extremely hard with the Global Fund to fight AIDS, TB, and malaria to make sure that this near point-of-care diagnostic machine that was a game changer because it let sites understand whether this was regular type TB that's susceptible to all kinds of medicines or if it had a critical drug-resistant strain. We worked really hard to get these machines all over the African continent and a lot, and beyond. And lo and behold, when COVID-19 hit and the company generated a cartridge, you can see those cartridges there, generated a cartridge for COVID-19, then all of these countries that had the Gene Expert machines had, near instant access to PCR testing for COVID-19 as well. I also clipped a bit from Dr. Lisa Chen over in San Francisco, and the Curry Center gave this fantastic presentation for the NAR, the North American Regional Meeting of the Union, the International Union Against TB and Lung Disease meeting back in February, just this past February. It's my favorite conference. I highly recommend it. There's a link to how to go and pay the discounted fee and listen to the entire thing, also on the resource page. Anyway, using TB experts' inputs, they created this thing called CalConnect, which was an amazing data tool that connected the case investigation information with the actual the contact tracing and the case investigation. And of course, now that it's created and TB doesn't have something exactly parallel, you're thinking, let's feedback this advance. And we're going to say more about that in a little bit. Continuing with the amazing contributions that the TB community has given, contact tracing, community outreach, going door to door, the home visits and the mobile diagnostic vans that we had already created in various communities. And here are two fantastic photos, clips of articles from Dr. Madhukar Pai. If you do not follow him on Twitter, you must. He is probably the most prolific TB, infectious disease, health equity, global health author that I know. These are from his Forbes. He regularly publishes in Forbes.com. And the second one, I want to point to the second one particularly because it echoes this idea of what Dr. Lisa Chen was addressing in the NAR talk that she gave, is that, well, we've had these leapfrogs now, and so let's start feeding some of these innovations to address TB and perhaps all pandemics, certainly all airborne pandemics, strengthening infrastructure in general with an eye towards future pandemics. Okay. Now let's get into this policy, economics, and equity thing. This is World TB Day 2014. It's Tom and myself with a local TB hero, Girish Mehta, he founded the Indian Sharing Circle here in Massachusetts. So quick start with them. What policy? We're going to start with policy. Why policy? I think this quote from Dr. Virchow, father of social medicine, because I love how it pulls out the idea that, medicine is more than just syringes and sutures and surgeries and pills. It is a social science, and politics, and I'll broaden that out to policymakers writ large, is nothing else but medicine on a large scale. And so the problems that are seen on the front line, we have to bring those back to the policymakers, because that is where solutions often lie, or at least a key portion of the solutions lie. And we have seen what happens when policy goes wrong and does not serve pandemic response, okay? That boom bust cycle of funding does not help anybody. It doesn't save the bodies from stacking up in the street. Now, a lot of the folks, the longtime folks from TB will immediately recognize this as the 30-year-old commentary from Dr. Lee Reichman from 1991, the U-shaped curve of concern. And this curve shows how TB was dramatically increasing in New York City at the same time that both the city had just spent 5 years of cutting TB services and public health services in general, and the federal public assistance went down from 1.4 million in 1709 to a fraction of that in 1980. And the policies that can help respond to pandemics or can help hinder that response can happen at every single level, federal, state, super, super local. One of the things that we've been struggling with in the TB world is in the United States, we don't have a national healthcare system. We don't have a single payer system. So we rely a lot on private insurance billing. And when a TB patient goes in and gets billed, they incur a copay or a high deductible. And that's part of what's happening. There's a broader trend of insurance companies selling more or requiring high deductibles. And that is going to give incentives for patients not to finish their treatment. And when we're talking about airborne diseases like COVID, like tuberculosis, that does not serve the population at all. But what can we do about it? It doesn't have to be this way, right? And that's one of the key things that Tom and I were doing in our free time with the chairing the Stop TB Massachusetts work in the State House. Every year we would do somewhere between 20 and 120 visits with staff and the legislators themselves. And we would always start with a basic TB 101 and then broaden it up to explain a little bit more about the public health infrastructure in general and connect it directly to, usually it was budget season, so what was happening in the budget. And there is definitely something to be said for the consistency here, because when we first started, he in 2003, me in 2004, fully a third of the folks we were talking to would say, wait a minute, tuberculosis? Didn't that go the way of the dodo bird? And we'd have to say, no, unfortunately, it's the leading infectious killer in the world. I would say that in the last 5 years, I've only gotten that reaction maybe twice in all of the visits that we had accomplished. So things build up over time. Another critical illustration of this comes from the results.org volunteers. Now, Results is a grassroots organization. It has 40 years of experience of just everyday people using their voices to shift lawmakers' decisions on poverty reduction. They were absolutely essential in the creation of the Global Fund to fight AIDS, TB, and malaria. There's some other really exciting, brand new successes, but every year they had bipartisan successes. And what we saw, and I specifically put here the fiscal year amount that was actually passed into law and given to the bilateral TB aid through the USAID line in the foreign assistance budget, an increase. You'll notice it's an increase every year, and this is despite presidential budget after presidential budget proposing a cut. And so the individuals working with their own members of Congress collectively together had this amazing result, and over time, successes over years. And again, this building of consistency, time, year after year after year. My favorite story from Capitol Hill, I was born and raised in Iowa, and so in addition to visiting members of the Massachusetts delegation, I would go to Senator Harkin's constituent breakfast because it didn't conflict with any of my other meetings. And I would go in there, Senator Harkin would go around the room and shake everybody's hand and speak with you like a human being for a few minutes. And so when it came to be my turn, I shook his hand and I said, Senator Harkin, I'm originally from Hinton, Iowa, and I trained in education in Iowa State University. But I don't want to talk to you about education. I want to talk to you about tuberculosis. And he cut me off. And he said, tuberculosis? Did you know that 2 billion people have tuberculosis? I said, Senator, that's my line. And what had happened is just the week prior, our TB champion in Capitol Hill, Senator Sherrod Brown, had called an actual formal hearing with lots of expert testimony to help educate his fellow senators. And boy, did that make an impact. All right, why equity? If a picture is worth 1,000 words, this picture calls out 1,000 or millions of lives. This is the life expectancy loss of years from a recent vital statistics publication. You can see that whereas white people have lost just under a year of life expectancy, Black men have lost 3 years. I don't know of any starker illustration of the urgency of what we are about. Because of course, TB lives at the intersection of inequity. And to respond to that directly, I bring you this incredible story from Chicago's vaccine campaign. It comes from the Trade-Offs podcast. The link is here, and it's also in the resource page. They literally went from 18% of vaccines to 51% of vaccines going into arms of Black and brown folks. And what did it take? A lot of persuasion, specific policies to collect the data and follow the data with their vulnerability index. And they matched that to the neighborhoods that were going to be prioritized. And the head of the public health department talks about, I had to say no. Like, she had to really be a bulwark against a lot of people making a lot of demands in order to follow through with this equity plan. And by golly, they did it. And they had to go door to door, and they had to do community outreach. And when I say talking to policymakers, it's every single layer down to the school committee and the principal themselves, because that was the school, the high school was the only safe place in that particular neighborhood where they knew people would actually show up to get their vaccine. It's a great story, very good listen. And that whole story parallels perfectly the amazing presentation that Denver Public Health's Dr. Berman gave. He was the keynote speaker of the lecture Beyond TB at the recent NAR conference that I won't shut up about. The link is in the resource page. And I really wanted to lift this particular information from his talk, lift it up to you, is that he labeled it the framework for addressing systemic racism and classism, because the exact same things that were causing so much disproportionate harm and impact with the COVID-19 that he was seeing, he acknowledged. And we know TB, point for point, starting first and foremost with race and ethnicity and the housing situation, right? So here's his formula that he spoke a lot about, local data, and he said, don't wait, like we had to make a move before we had perfect data, so go with what you got and keep improving along the way. The communication, he was critical that it was both to the public and the policymakers. And when you do it with the public, he said, engage, go deeper and engage the patient's family, the community, right? The system level partnerships really grew a tremendous amount of fruit for his efforts, and both in policy and funding. And one of the great bits I'll share with you here is that they took that local data. They had done heat maps of where the COVID cases were and where the vaccines were going. And those two heat maps, the maps did not match up. And so he took that to one or two of the largest health systems in the Denver area and made the presentation. And the health system people were like, oh my gosh, this can't stand. And so they put in their own resources and advanced their own specialized neighborhood outreach vaccine clinics. And it really changed the numbers, evened out the numbers. And then constancy, again, I've been developing this theme here, but the constancy, the long-term commitment to key issues and communities. One other thing that really jumped out at me that he mentioned was he was surprised at how effective community organizing was. And of course, anybody who from the organizing world is like, yeah, that's why we do it. But there's another great link to another great NACHO webinar that specifically addresses and tells great inspiring stories of local public health connected with not just community-based organizations, but community-based, community organizing organizations. So that link is in your resource page as well. Another thing, I mean, Dr. Berman, it was a very inspiring talk. Jumped out at me, right? He said, don't call them case investigators, call them case supporters. And I thought, duh, because they, more than just trying to find the new cases of COVID-19, those folks were also trying to say, hey, do you have a safe place to isolate? Maybe we can get you a hotel room. Do you have, like, do you need groceries? They got down to that absolute basic level. And again, from the TB world, we know about enablers. From the policy world, a lot of the budget cuts meant that we didn't have as many enablers as we would want in the TB world. So, you know, making those connections. But I'd be remiss, because that jumped so sharply out, I'd be remiss if I didn't call out and give you these resources on an existing campaign to end stigmatizing language in TB, because that is going to be a critical and essential part of our solution of where we're headed. Okay, third, why economics? Well, at a minimum, and in a very concrete way, economic evaluations can help you concretely highlight the broader costs of interventions and policies and underscore when policymakers or we the public are penny wise and pound foolish. I mean, here's a classic example from Freudenberg et al. When they calculated the cost of the three syndemics of tuberculosis, HIV, and homicide in New York City to the tune of $50 billion, 2004 dollars, whereas that control board that was given control of New York City's financing cut only $10 billion. Another thing about policymakers and economic evaluations is that they always want to see the numbers, right? They're always interested in seeing the numbers. Sometimes they demand them, sometimes they're just interested in them. But be aware that the decision will be made with or without economic evaluation support, sometimes or all the time, because policymakers have to make the decision from a much broader context, including and sometimes especially the political context. So there's always an awareness that you have to build around that. And then I'll just, this is a teaser for the messaging section. Straight from frameworksinstitute.org, the recommendation is in messaging, don't lead with the numbers. Instead, start with a broadly shared value like justice. And we're going to get more into that. Okay, continuing with the economic situation, I thought I'd give just a super quick economic evaluation primer, lifting up cost-benefit analysis first, because it does answer the value question, but it can also answer the question of, is it worth expanding a budget for this intervention? Whereas cost-effectiveness analysis, it answers the value question, and its specialty is how to get the most value out of a given budget. And then, of course, budget impact analysis is when you're answering the immediate questions of affordability, very short-term, very specific, very narrowly focused. But there are positive developments, particularly in the cost-effectiveness world. The second panel, fairly recent, 2016, I want to say, there's a reference in your resource page. The second panel on cost-effectiveness in health and medicine emphasized the need to have two base cases, the societal and the health system. So rather than just showing the impact on the hospital or the public health delivery system, show the broader impact of the society or the population as a whole. And taking that idea even further into a more granular level is this new methodology called distributional cost effectiveness analysis. So with that, you're not just going to get the total costs and the total effects, but rather you're going to answer the question of who wins and who loses and by how much. All right, so watch that space because that's a fairly new kid on the block. There's also critical humility. I feel like humility is needed in everything we do. But here especially, you're only as good as your assumptions and your data. Lest we forget this original sin, when the WHO recommended do not treat people with drug-resistant TB, largely that decision was based on a cost-effectiveness analysis that had the fundamental flawed assumption that multi-drug resistant TB would not spread as easily as regular TB. Now, of course, fast forward 10 years and we have whole genome sequencing and we realize, okay, maybe that was not so crazy of an assumption, that TB actually had 2 mutations, one that helped them be resistant to the drugs, but also another one that helped them spread even though they were resistant to the drugs. Nevertheless, the epidemiological information showed, and the health equity lens showed, that these people were dying and suffering, and we wouldn't stand to it. And I give a big shout out to the Partners in Health crew who really pushed that envelope forward back in those 80s and 90s, the early days there. Another thing, just best practice, be transparent as possible with any of these economic evaluations. I looked up as a fun example the article I did with a tremendous, again, a tremendous crew, the International Journal of Infectious Diseases in 2020 was a community-based intervention against dengue, but especially the appendix, and this is a hot tip. If you ever want to understand any of these economic evaluations, or if you're considering your own, be sure to get the supplemental material and the appendices, because that's often where you're going to see the bulk of the assumptions and or other, you know, in the realm of hypotheses and some other really interesting information that, you know, never fits in that actual journal article. Okay. Now we get to celebrate some more, right? Because good things happen when you get out of your silos. But first, this is Tom, who is literally giving tuberculosis to his favorite senator, Senator Donnelly. If you've never seen it, Tom was famous for showing his plush tuberculosis or bacterium, throwing it out into the crowd and saying, hey, you see, that's how easy it is to catch TB. His humor is going to be sorely, sorely missed. But more celebration. When you put a dream team together, this is a very small example, but it has Tom, it was a critical part of it, so I definitely wanted to share it. When we were doing this, I had been thinking and writing on integrating TB prevention services in the primary care sector for a while. And this course that I took with the amazing Professor Deb Garnick here at the Heller School at Brandeis, so she had this amazing, it inspired sort of it was the final chispa that I needed. We had her expertise from the performance measure perspective, and she also knew the journals and the literature extremely well. And then we brought on, I recruited Dr. John Bernardo, the TB medical officer for tuberculosis, so, you know, as much TB expertise as you could possibly hope for. And then Tom was the critical cornerstone for this team because he had the primary care experience. And we didn't want to propose anything that couldn't actually be implemented in the primary care sector. And so if he said it was not, it got cut out of the article. And we submitted it, and it was accepted with no revisions. Something else that Tom and I were involved in Massachusetts, you might remember 2008, 2009 weren't great years for the economy. And instead of just the trickle of budget cuts, there was a proposal to slaughter the public health infrastructure. And it was horrifying. And so with the leadership of Tony Palumba at Health Resources in Action, we helped, Tom and I and Tony created the Friends of the Hinton State Laboratory. We upped our game on outreach to offices. And then when the cuts seemed to get even bigger in 2009, it was a huge coalition, that broader coalition that happened, and we actually ended up stopping that particular budget cut. Here's another just amazing success story, and I put this up. The reason why I put this up was because I was listening to Dr. Dick Chazen present on this recent trial in January. He was talking about it, and he literally said, this would not have happened. This game-changing, major milestone of eliminating 2 months of toxic treatment for these TB patients would not have happened had it not been for the coalition and the collaboration that they brought together. It was because of that groupthink that they had, oh, let's not just do 1 new regimen, let's do 2 regimens, because it wasn't the first original regimen that they were targeting, especially, that turned out to be successful. It was the second one, the moxifloxacin plus rifapentine, and then the traditional isoniazid and pyrazidamide, right? And you can see from this list on this slide that it was a huge collaborative effort from a lot of different people in a lot of different walks of life. All right, shifting gears now into public health messaging. You can tell that Tom and I had a lot of good times. We very much enjoyed what we did together. Most of this comes from a recent NACHO webinar, where they invited Dr. Sweetland from the Frameworks Institute, frameworksinstitute.org, to share a plethora of their recent research from a wide range of public health campaigns, from tobacco to oral health to aging to maternal outcomes. Okay, and so this is a condensation of a lot of their recommendations. I'm going to focus on 3 recommendations, starting with the justice as a shared value aspiration, pairing it with collective solutions, and then giving people a reason for what they're seeing. All right, and in terms of the justice as the value, the broadly shared value, the choice for framing, rather than using the actual health equity phrase, is they said that in general the public they don't understand health equity like, you know, what we in public health tend to understand it as. And so this idea of justice, or communicating, even if you don't use the actual term social justice, they said you know your audience best, or your local population and opinion, but describing the idea of justice. So one example here came from the tobacco campaign. A just society makes sure no community is singled out or overexposed to harm. And then from there, they would flow into examples of how particular communities are unfairly targeted for extra advertisement for these harmful products. And in fact, they found that just mentioning unequal outcomes is not as good as the unequal obstacles, in part because what some of the listeners, the public, where they would go if they just heard unequal outcomes was this, oh, well, that's just the way it is. So it wouldn't assist you in helping move folks toward a collective solution to the topic you're working on. Somewhat similarly, the targeted justice frame worked better than the one-size-fits-all, we have to have equal opportunity or give everybody the same thing, right? And by testing better, what I mean is that folks who heard the targeted justice message, they actually were more supportive in sort of the post-game opinion polls. They were more supportive of culturally and linguistically appropriate care. They were more supportive of collective, or they were more likely to see our collective responsibility for these issues. And they were also more likely to see the systemic or the system involvement in these health inequity issues. All right. Now, pairing with collective solutions. Why pair with collective solutions? Because you can point out what's wrong, but you're leaving support on the table. The other thing that you risk if you don't give some kind of solution, even if it's just a partial solution, is and point to the collective ones, because sometimes people will go to the individual, they have to fix themselves. The other thing that you can trigger is this fatalism of, well, you know, that's just the way it is, and there's nothing we can do about it. Sigh, I'm going to go, you know, same old, same old. And then most powerfully is when you pair it with some kind of explanation. Again, it doesn't have to be the total explanation. It doesn't have to be the slam dunk causation. But if you don't give people some explanation, it's going to go back on the default. And unfortunately, particularly in the United States, defaults tend to be things are broken beyond repair. There's nothing I can do about it. Not seeing the systemic situation that's causing the problems, that kind of thing. So really what we're trying to do is connect and highlight the root causes and the cascading consequences for folks. And there's a direct link to the full recording and webinar in the resource page. There was something else that I picked up as I was preparing, this really fun website and toolkit, particularly focused on public health messaging. It's a joint venture between Hadaway Communications and frameworksinstitute.org, and there's tons of resources and toolkits there. One of the really specific recommendations I wanted to lift up here, highlight here, is connecting with the core mission of other sectors. So what they're finding, folks who follow public opinion broadly, is hashtag silver lining. The COVID-19 has actually helped more people see that public health, or support public health in general. But the problem is that the average person does not understand who does public health or how they do it. And so it's really important to give very concrete, tangible examples of the benefits of working with, of partnering with the public health. So for example, if you're approaching business leaders, you can connect the fact that improved community conditions via public health intervention X, Y, or Z can help reduce absenteeism. Or when you're talking to school leaders, the idea that better student health because of public health intervention X, Y, Z can lead to higher graduation rates and higher test scores. So the resources are also there listed. I am an academic, so I have to do the limitation section. There's no silver bullet. Some caveats, provisos. Here we go. There are hard choices to make often when you're thinking about how to frame things. And by framing, it's just the choice. What we mean is just the choices of what you say, you know, the vocabulary that you use, the emphasis that you give, what you don't say. And sometimes that narrow focus might be required to have a specific immediate gain, but you will exclude some members of that population that you're trying to help. There's a citation from Fujiwara 2005, comes from the immigration world on that in the resource page. It's similar here where you've got that short-term win versus the long-term goal, and I encourage folks to spend some time, well, for this very short-term campaign or decision that we want to help influence or shift in a particular direction, are there biases or stereotypes or frames that we're going to deliberately or not deliberately, inadvertently support that will actually undercut your long-term goals, particularly around health equity? Thirdly, it matters who the messenger is. I mean, the psychology research, for example, Bollock and Fennell from 2005 have been saying this for a long, long time. But, you know, the Chicago example really shouted this out. The Denver example I gave really shouted this out. Tom and I found this out in the State House work, because when we actually went out, and, you know, Tom gets the bulk of the credit for finding local public health nurses or folks on the front lines and brought them to the State House and brought their stories to the State House. My gosh, they, you know, the offices that represent their districts, those folks were captivated. They were absolutely captivated. And I also lift up as a best practice betweenus, aboutus.org. If you have not seen this, it is delightful, best practice. And finally, one other hot tip from the Frameworks Institute was they found that leading with economic impact actually backfired in terms of it reduced, and this particularly was a tobacco intervention study, it reduced support for the tobacco intervention because people started blaming the individuals for the bad economy. So watch that quicksand trap. There's also, similar to the fact that the COVID-19 disaster has increased public support for public health, or at least awareness, it's also shifted the idea of what people have of government. And so again, as I was doing these slides, jumped into my a newsletter from Frameworks, jumped in my inbox and called this out and said, encouraged anybody working on social issues to share a news story about government as an essential part of providing and protecting the common good. Again, Tom and I had to do this a lot in the State House because TB just isn't on top of the mind. People don't know a lot. In fancy speak, they say it doesn't have a lot of salience for the public. And so we would always have to put it in the broader context. And so talking about government, well, this is fundamentally an essential role of the government. Who does surveillance, right? Private business doesn't do surveillance. And reporting out those critical epidemiological numbers to help us move forward on response, collective response, coordination, right? And so these are 5 key recommendations that are given. And you have this, and you will also have this in the slides. This is a specific example that they gave to illustrate how to put all 5 of those recommendations into practice at once. You'll have that as a resource. But I want to stop here, park here for just a little bit. We are now in a unusual for TB position where billions of dollars are flooding, particularly the public health, or are going to, right? First, we have to make sure it gets here. And the main question I want to pose is, will any of this money help us be directed toward catching up on TB or even conquering TB and other pandemics, long-standing pandemics, and build the future so that we are actually ready for the next pandemic? Because as Tom and I we're fond of saying in the State House, it is not a matter of if, it is a matter of when. Will it happen? Because when that money starts being allotted, you've got a big chunk of money going to the CDC. Well, is the CDC going to allot any toward the TB division? And when the fiscal monies get to the state, will the state allot any toward the public health? And when it gets to the public health, is it going to go to just the same old, or is it going to build an actual broader partnership, have more buy-in from the community? Is it going to really focus on health equity work? All of that depends on us speaking up, whichever level you feel most called to. That's probably where you should be speaking up. And we need to make sure that we're connecting with the community and the media and the policymakers. So there's a toolkit here, there's a link, it's super basic. It starts at the beginning of how do I make a meeting, or how do I write a letter to the editor? And then, because I recognize that a lot of people who work for government, they have specific restrictions on what they can say and to whom they can say it. And so there's this really great decision tree link here from Public Health Awaken that follows all the different restrictions, and you can find what you actually are able to do. So, in summary, and as an homage to Tom's nature photography, you only remember 2 things from this presentation. Make friends. All kinds of different friends. Work with lots of different people. 2, speak out. I mean, really.
Thank you so much, Dr. Chancel. So it looks like we have about 15 minutes for questions. I don't see anything in the chat box, and I want to be sure I'm not missing it if it went to all participants, and for some reason if I can't see it. So if I am missing anything in the chat box, please let me know. But Dr. Chancel, again, thank you so much for your lecture and for all of your advocacy work. So I can get us going with a couple questions here, and certainly, again, feel free to put anything into the chat box. So, Dr. Champel, I guess I'll start with you, and maybe that last slide, or one of the last slides that you had up, may kind of be the start to the answer. But you know, you are very good at policy work. You have done this, you know, it seems like probably your whole life. I'm just wondering what, you know, maybe specifics or advice you could give to kind of the rest of us here who maybe have never done any kind of policy work. Seems kind of foreign and almost untangible. And maybe just some specifics for how people could get involved, even just on a small scale. Not something that would become kind of a new career, but just even kind of small specific actions that people could take if they wanted to start getting involved with advocacy and policy work.
Absolutely. I mean, this was the first hot tip is make friends, because there are lots and lots of people across lots and lots of sectors who are doing this. So the chances are that you are only 1 or 2 degrees of separation from somebody who does this really well. And then this resource page right here, and again, like for anybody here, download, you know, it's 2.5 pages of links and resources. So there's additional resources there, but these were sort of the 2 top ones, the lowest bar of entry, if you will, in terms of where to begin, because the results toolkit really starts at the very basic. And if you tool around the results website in general, there should be a place where you can say, hey, is there a chapter, because we're all volunteers, is there a chapter in my neighborhood or in my state that I can connect to? And you know, I've never known a results chapter that didn't want another person, even if you're just hanging with them, to learn the ropes and you know, do advocacy with them or policy work with them for a few months to learn the ropes. It doesn't take a long time. It really, really doesn't. And I will say that once you have that authentic experience of agency, because they listen. Policymakers are people, right? And their staff, this is what they do so much of each and every day. So you really get the sense of agency, first from the meetings that are almost always going well, and then over the long term when you start to see incredible improvements or successes, that will also keep you going.
So maybe I'll ask Dr. Jacobson questions for you. So looking at that graph that Dr. Champel had in her lecture about the loss of life years by race for tuberculosis, it certainly seems like that could be kind of very similar to COVID. And I'm just wondering if you could touch on what you think maybe we've learned from COVID that could help us with the care and management of our patients with TB.
Thanks for that question. Yeah, I mean, I think really what COVID has highlighted for us is that when we think of different racial and ethnic groups, we really need to be thinking more about access to care and some of the really what have been some of the barriers that our various societies have set up against different groups really being able to access care successfully. So rather than thinking of this as somehow biologic or somehow something that is specific to a certain group, we really need to think about what have been more historical barriers to care, in, both, like I said, physical access as well as messaging, as well as a lot of those key components. And so I think really taking, similar to what we've done with HIV, where when a lot of resources have been put in, we've come to understand novel jumps of how to improve TB care. I think one thing we really need to do with learning from COVID is everything from, you know, when we talk about vaccine hesitancy, we realize that unpacking that for different groups is going to really mean something potentially different than just simply breaking down by ethnic groups. I think also recognizing that the years lost is not even across groups is also just a good reminder. And I think it's something that we've known in TB, but it's helpful to see it illustrated again in another sort of pandemic disease, especially one that we're seeing more domestically.
Great, thank you. You know, as an infectious disease physician, you know, I will say that the social determinants of health that both of you talked about in your lectures, for me, over and over again, whether I'm treating HIV or hepatitis C or TB or COVID, you know, the actual medical treatment part is usually relatively straightforward, what I'm supposed to do. But delivering this care to patients, it's those social determinants of health that make it so difficult. It's the transportation, it's the stigma, it's the having people stay at home and missing work, and maybe they don't have any, you know, they need to support their families. And so it's all of these that become really the main barrier to treatment. And so I guess, you know, we have a couple minutes left here. Maybe just, you know, Karen from the clinical side, you know, what, you know, any advice to how we can try to move forward with this, and Cynthia from the policy side, how it is that you try to make this part of healthcare important to the policymakers when you're talking about budget.
Yeah, I mean, I think in the care delivery, some of the interesting questions that have arisen, at least here in Massachusetts, has been, so what's going to be the role of telehealth? So, you know, traditionally we've really avoided telehealth for delivery of a lot of care, and there's been thoughts about what are the barriers there in terms of people having access, or people have moved towards video telehealth. And I think rather than just abandoning and saying we're going to go back exactly to how we were, these are the kinds of individual efforts. How do we bring healthcare to populations rather than always expecting populations to come to us in the healthcare system? And I think another piece is, how do we message prevention? I think there's been, you know, just huge recognition that public health messaging is so nuanced, and maybe this actually, Cynthia, links nicely into what your response may be, but that we need to recognize that public health messaging needs to have multiple versions, repeated messaging. We need to show nuance, because I think people don't believe if we don't show the nuance. And I think COVID's been a good reminder about what's good or bad public health messaging, and I think that's another piece as a provider and someone who works in public health that we need to continue to practice and maybe work together in terms of, particularly when we're talking about prevention, because people find it sometimes harder to wrap their minds around doing things when they don't feel unwell.
Thank you. And Cynthia, just in the last minute, any thoughts about how you make that important to the policymakers where they might not see that part of healthcare?
Yeah, absolutely. So I first bring up this slide here because Dr. Madhukar Pai, in that article, It's Time to Use COVID-19 Innovations and Systems, he goes through the works, the diagnostics, the community relations, the AI, etc. There's a huge number of now leapfrogging, but the community, the delivery, the mobile delivery of medicines, fantastic ideas. And these are the kinds of things that we can bring to policymakers and say, you know, let's not let this COVID-19 moment go to waste or to disappear like the SARS. You know, we would have had more antivirals had the SARS research continued, but they went away after the SARS emergency ended, right? So let's link onto these innovations and use them for TB, but also for building the broader infrastructure. And then the other thing is social determinants of health. Housing, I think, is the primary among them, both for COVID-19, for TB, and likely for the next pandemic as well. And part of the suggestion is to make friends with the housing coalitions in your neighborhood and go together, do joint projects, or every project that you're thinking about, invite input from the housing coalition folks, and there is billions of dollars for housing. There are also billions of dollars in just fiscal relief. So something creative can happen out of that. Like, this is really, I cannot emphasize how much this precise moment in time can present an opportunity for well, building back better, as they say.
Great, thank you. So it looks like this is all the time that we do have allotted today for the webinar. We're right at the noon hour. And so in honor of Dr. Tom Garvey on World TB Day, I would like to thank everyone for joining us today. This will be an annual event, so we do hope to see everybody back next year. I'd like to thank the planning committee for their hard work in putting this together, to thank our speakers for keeping us educated, up to date, and motivated as we continue to work toward the goal of TB elimination. And really just a very, very special thanks to you, Kathleen, for being here today with us as we honor and celebrate the life of your husband. Thank you all so much.